placental hypoxia and ischemia. Firstly, it leads to fetal growth restriction leading to IUGR. Secondly, there is release of pro-inflammatory proteins into maternal circulation, which in fact leads to endothelial dysfunction leading to systemic vasoconstriction, which in fact leads to maternal hypertension, and there is major organ damage like in kidney, retina, liver and brain. Symptoms are most common in third trimester, including blurring of vision, photopsia, scotoma, diplopia. Ocular findings include conjunctival vascular anomalies, hypertensive retinopathy, choroidopathy, exudative RD, vitreous hemorrhages. Earlier, there were very few clinical studies regarding the retinal changes in eclampsia and preeclampsia, as objective and quantitative retinal imaging methods were lacking. So my aim is to study the RNFL changes in the pregnant woman with gestational hypertension and establish the potential contribution of OCT as an eclampsia predictor. It was an observational prospective study including all the patients in the age group of 18 to 45 years diagnosed with gestational hypertension by the Department of Obstetrics. We excluded pre-existing diabetes, hypertension, renal disease and any other retinopathy. An informed consent was taken from 35 patients after satisfying inclusion-exclusion criteria. Details pertaining to medical history, family history of hypertension, age, parity, gravida, BP, baseline data all were recorded. A comprehensive ophthalmological examination including external examination, BCVA, slit lamp, IOP, fundus evaluation and peripapillary RNFL thickness was measured at first visit, at 28 weeks and 2 months postpartum by HD-OCT. The severity of PIH was classified into mild and severe preeclampsia and eclampsia according to ACOG guidelines. Now highlighting the results and discussion, maximum of the study population belonged to the age group of 20 to 40 years. One of my youngest patient was of 20 years. There were 23 primigravida and 12 multigravida patients and maximum of them belonged beyond 30 years of age group. According to ACOG guidelines, there were 28 mild preeclampsia and 7 severe preeclampsia patients. On comparing the RNFL thickness from first visit to 28 weeks of gestation, in the mild preeclampsia group, 7 had thicker RNFL, 15 had no change, 6 of them had thinner RNFL. And in the severe preeclampsia group, 4 had thicker RNFL, out of which 2 patients ended in eclampsia with new onset convulsions who were terminated emergently, and 3 of them had no change. The mean RNFL thickness in the severe preeclampsia group at first visit was 96 micron and at 28 weeks was 101 micron. At the same time, there was no significant change in mild preeclampsia group. Highlighting the retinal changes, 13 patients had no hypertensive changes, 7 had grade 1, 6 had grade 2, 5 had grade 3, 3 of them had grade 4 hypertensive changes and 1 of my patient had exudative RD. Reddy reported that there were 53.4% retinal changes in the preeclampsia group and 71.2% eclampsia patients. These vascular changes in the retina, they typically correlate with the severity of systemic hypertension. Therefore, observing the retinal changes can help in assessing the disease severity. With that, I would like to conclude that preeclampsia was more prevalent among the elderly primigravida. There was thicker RNFL layer thickness in the severe preeclampsia group from first visit to 28 weeks of gestation. And likewise, there was no change in the RNFL layer thickness in the mild preeclampsia group. So on OCT with ocular fundus changes, it can predict the maternal risk, diagnose the patient early, and guide the obstetrician in early and proper management. So fundoscopy should be made compulsory in all pregnancy-induced hypertension patients, especially in elderly primigravida during the antenatal visits, and there should be frequent follow-up. HD-OCT can be used as a routine screening tool in all those patients to detect the retinal changes before any vision-threatening complications can occur. Thank you.
Yeah, very innovative.
Thank you.
But only one question I have.
Yes, sir.
Do you think OCTA has got some role to play?
So we can only predict the mine. I had only 35 patients, so a large multicentric. We can at the same time we can check the macular thickness, choroidal thickness, and RNF. Yes, sir. Everything it can be done in a large population. Then only we can generalize it to the whole data.